Thank you for being here.
Thanks very much, Stephen, and thanks for inviting me. So the challenge before me was reflect on strategies and tactics for how we can overcome this lack of harmonization. Let me start with a strategy. We learned over the past 2 days that this harmonization or lack thereof has two dimensions. One is the industrial policy, and the other is the public health policy. And it can only fly if those two can be made to converge, because there are different players, and they need a common business case. So I'm coming back to that issue of business case. But I'll try to have a stab, and I'll try to give it a name. I'm surprised it didn't come up. Some of you touched on it. I call it opportunity cost. Let me explain what I mean. Yesterday, we've heard a perfect example of disharmony is those little plugs that you use to go into the wall. Now, like everybody else in this room, I traveled a bit, so I know when I come here with my British charger here, I will have a problem. That is lack of harmonization. But I'm so terribly smart, like also everybody else in this room, that I get myself this little thingy here. And I can overcome the lack of harmonization with one little click. Hear that? That does it. So that is a situation of high disharmony, but low opportunity cost. If tomorrow the global electric appliance industry tells me we harmonize everything, there is only one plug and socket under the sun, as a consumer I'd say, fine, I welcome that, but it doesn't change my life. Why? Because the opportunity cost is so low. This thing costs me $5 to $10, and that is the opportunity cost of 1 or 2 frappuccinos at Starbucks. I can handle that. Now, let's come back to medicine. Before I attended this meeting, by pure coincidence, I was at another IOM meeting in the other building that was on cancer drug development. And there the spirit was, we live in a world of infinite opportunities and limited resources. What they're saying is, through genomics and other progress in our basic understanding of cells and pathomechanisms, we now have so many druggable potential targets. There are so many mutations out there. There's a gazillion of combinations of mutations that the amount of opportunities to look at and to go into development is almost infinite. But the resources we have, the amount of money to channel that through clinical development into treatments, that is very limited. So here we are in a very different situation. Here, opportunity cost is at the forefront of our thinking. And I posit that lack of harmonization requires duplication, equals inefficiency, equals opportunity cost. So this is really the strategy that we should follow. Now, we heard from Peter Honig yesterday that opportunity cost comes in different shapes and, shall we say, sizes. He told us that some of the Asian jurisdictions, for example, want a PK study for their country. Does that come at a high opportunity cost? I don't know. I did PK studies when I was younger in academia. Yes, there are investment. Yes, they are cumbersome. But they don't cost the world. They can be done concomitantly with other studies. So that's reasonable, presumably. Where it gets difficult is if a company has to do their 12,000 patient cardiovascular outcome study. And let's assume there are 2 big regulators. Not that that ever happens, but let's just assume they could not agree on what is the appropriate comparator, what is the appropriate dose, or the end point. In that case, 12,000 becomes 2 times 12,000. That is a huge opportunity cost. That money that has to be thrown at that product cannot be used to something else. And yesterday, in one of our meetings, someone else said, look at Africa. We find it so difficult to start a multinational clinical trials because of these multiple exigencies. They don't talk to each other. It's very difficult. So I would say to my colleagues in those regulatory areas and to my own colleagues, look, if the resources are only enough by all the sponsors, let's say for malarials, to take at any given year only 3 drugs through this funnel of clinical development, but we have many more opportunities out there. We can only do 3 a year because we're inefficient. If we were more efficient, we could, instead of 3, so let's say 10. I'm exaggerating for effect. If you start with 3 candidates, you will end up with 0 drugs, because that is the attrition rate. We know that a priori. If you start with 10 drugs, and a bit of luck, you might have 1 treatment. Huge difference. So opportunity cost counts. I would say the business case is, for regulators, it's almost what someone used that term, a moral imperative. So the business case for regulators is, you have to do it. You're morally obliged, because otherwise everybody suffers. It's not just good industrial policy to increase efficiency, it is good public health policies. Because, remember that, infinite opportunities, limited resources. So that's the strategy. Now, more mundane, the tactics. Tactic is sort of the day-to-day little how do you maneuver. And we have heard from a number of people, I think Toshi had a slide, with several layers of what you can harmonize. And you start out with standardized terminology or science, and then you go up to implementation, policy, etc., all the way up to decisions and legislation. And I can only speak from the European experience, and we have a little bit of experience in that, and may not be applicable to all, but just food for thought. There are 2 ways to start. One is top-down, the other one is bottom-up. And I would never have dared to say that, but someone else said something about the lawyers. So if you start top-down, you start with the lawyers. If you go bottom-up, you start with the scientists. In our experience, we find the latter far more productive. So start with a scientist, start with pure science, and then go up, not the other way around. I must say I learned something today. I thought the issue of units was a scientific thing, until this morning I heard that it is hugely cultural and political, whether you use US or SI units. So that is something maybe where I would shy away from. Let's start from the ground and go up. And there is something else in terms of tactics. And that is the human factor. And we're always shy to address that. We're all human beings. We're not just systems. Now, whenever you ask 2 people to harmonize, it means that they have to compromise. So we're all outside our comfort zone. We've always done it this way, and now someone says, do it a different way. So it puts me outside my comfort zone. How can I mitigate that? How can I lower that threshold? And again, an experience that we have had, and it came up sometimes in the discussion, start with non-committal meetings, what we call the safe harbor. I think that has been a success strategy. A safe harbor, from that we could move on to pilots. A pilot is still not so threatening, because you do one, if it goes well you do another one, and the third one. We're doing this just now for a few things where we try to change our modus operandi. We could never have gotten our own body of individuals to do it if we hadn't said it's a pilot. We just try this, then we try that, and so on. So from the safe harbor, we progress to the pilot. From that, you progress to a process. And then, I wouldn't say this is insignificant. I think it's very, very important. Then you start with a secretariat and a full-fledged apparatus. But start with a thin wedge and then go wide. So I hope that is thoughtful about both strategy and tactics.
Okay, our 3rd speaker is Alan Morrison, who is Vice President for International Regulatory Affairs and Safety based in Europe at